Okay, this is part one of 3 parts that talks about movement dysfunction. This first section is specifically talks about the pathophysiology of cerebral palsy. The objectives for this first section are we're going to look at the 5 major centers of the CNS that are implicated in CP, and specifically we're going to look at the areas of the brain and noteworthy signs that go with each of the 5 major centers. We're going to look at the common causes of CNS pathology and specifically look at the grades of an intraventricular hemorrhage and functional losses associated with damage to structures in the surrounding areas of the ventricle. Cerebral palsy is an umbrella term referring to a non-progressive disorders of movement and posture. When we say non-progressive, this means there's been some sort of brain insult or injury that occurred before birth, at birth, or within the first year of life. It has a variety of types of manifestations and prognosis for each of those. So the degree of severity and the distribution of tone is going to be different in each of the different children, and so therefore the outcomes are going to be different. Medically, it's known as static encephalopathy. I've had many children who that's what the physicians used, that diagnosis, as opposed to the more common layman term of cerebral palsy. And static, as you know, just means non-progressive. It doesn't change. And encephalopathy refers to the brain. So there's been some sort of brain damage occurs as a result of many factors that we'll talk about in a minute. However, if you think about it being non-progressive, the lesion itself, or the damage to the area of the brain, may not be, but there's many outcomes that are a result of that aren't particularly non-progressive. Babies, many times when they're first born, are very floppy or very low-tone infants, and this results later on in life as they begin to move against gravity or have voluntary movements. It produces children who have athetosis or spasticity. In that same light, spastic diplegia, which is a type of CP that it involves primarily the lower extremities or more involved than the upper extremities. But the symptoms, especially if it's a relatively mild case, children don't start to pull up to standing until about 9 or 10 months of age. And this is when the symptoms of spasticity in the lower extremities seem to appear. Well, I think it probably, the symptoms were there before. They were just maybe very subtle. And because you weren't moving against gravity, the tone didn't kick in. They want to move. They want to get from point A to point B. So they are very creative in how this dysfunctional movement will lead to compensations. For example, a child with spastic diplegia may walk on their tiptoes, and that causes a shortening in their ligaments, in their tendons of the Achilles tendon, which can lead to that lack of range of motion, can lead to a shortening of the tendon, which causes further problems. Disuse of the muscle leads to atrophy of the muscles and weakness, which prevents the child from having an adequate strength. Other problems that occur, just general disuse is going to decrease vital capacity, which is not going to allow the child to have adequate aerobic fitness, and it's going to lead to further respiratory problems. Children, many times, especially if the cause was due to prematurity, the children have respiratory problems to begin with, and so this just kind of is a vicious cycle. It's also the divorce rate in families with dysfunction is significantly higher, although the divorce rate is pretty high these days for everyone, but it is seem to be higher in children who have special needs. And I think that when you have maybe a family who isn't real functional to begin with, that they're dysfunctional, that this added stressor causes more problems. Children with CP frequently will have oromotor control problems, as it doesn't just happen in their arms and the legs, it's going to also occur in their proximal muscles, which poor Oral control is going to lead to difficulty in eating and feeding, which can cause problems with nutrition, which can cause problems with growth and development and overall health. The dysfunction can certainly impede the child's ability to move in their environment, and because of the decreased motor experiences, it's going to lead to the children not having the same experiences or exposures of other children, which is going to decrease their ability to problem solve and for adequate cognition. So, as you can see, even though the actual lesion to the brain is non-progressive, it's not going to spread, or the bleed isn't going to get bigger if that was the cause, but the problems as a result of movement disorder is very aggressive in nature. In the United States, there are approximately 500,000 Americans who have CP. And the most prevalent type is going to be children with spastic. Actually, it's probably more common. It's a blend of spasticity and athetoid component. It primarily occurs in children or infants prenatally or during the birth process. With a problem that might occur after birth would be, I think somebody last had shaken baby syndrome, a cause of acquired birth disorder. The last fact about CP is that children, many times it's a result of children being premature, but doesn't always lead to that. They have lower birth weight, but it could be a full-term baby with small birth weight. But most likely it's because they didn't get adequate nutrition or growth and nutrition during utero. So these babies who are born with low birth weight are 100 times more likely to develop CP than the normal birth weight infants. We're now going to discuss the 5 major centers of the nervous system that are involved in CP. Now, what I want you to know about each one of these is the area of the brain that the lesion occurs and the resulting what I call the cardinal signs. So before we get started with centers of the brain, let's take a little review of neuro and look at, this is a lateral view of the cerebral cortex. And if you remember let's talk about the functions of the frontal lobe. And this is where the primary motor cortex occurs. So in the motor cortex, you're going to get voluntary movement. In your premotor area, this is what's going to control the trunk, the proximal muscles. So you got your trunk and your girdle muscles, anticipatory postural control. The supplementary areas are going to look at inhibition of movement, orientation of the head and eyes, and bilateral sequential movements. Broca's area, the left side, the motor programming for speech, and on the right side of the brain is the nonverbal communication. So don't you wish you had me as your neuro teacher? Very simplistic. Okay. The temporal lobe, this is with the primary auditory cortex. It's going to discriminate loudness and pitch of sounds. And Werbuck's area is responsible for hearing and comprehension of spoken language. Okay, the next is the parietal lobe, and this is going to be implicated with our somatosensory cortex. This is our primary somatosensory cortex. So our kiddos with sensory processing disorders are going to have damage in this part of the brain. This is where we are able to discriminate texture, shapes, and size of objects. The vestibular cortex is going to distinguish our head movements and head positions. Its lobe is the occipital lobe, and is responsible for the primary visual cortex. Differentiates light, shape, size, and location of objects. And the anterior temporal lobe and inferior frontal lobe of the limbic system looks at the emotion, motivation, processing of memory, and our motivational drive to learn. Okay, this is the medial view. Okay, this is a slide of the medial view of the cerebral cortex. If you look at the temporal lobe, this is where judgment, emotional tone, memory, and motivations in relationship to judgment occurs. It functions with all other cortices and especially the limbic system. The prefrontal cortex is the last area to mature. It is, if you will, the CEO of your brain. And this is what tells you what to do, where working memory is, and anything recent in development is more vulnerable to damage. And you have your limbic cortex, and this is where memory, motivation, olfaction, visceral and emotional tone, basic survival mechanisms such as fear, anger, rage, violence, all those kinds of things. Kinship, bonding, reproduction, these are all functions with all areas of the cerebrum, and especially the reticular system and hypothalamus. Okay, so that's it for your review. Okay, so now we're going to look at the first major center of the brain that's implicated in cerebral palsy. And this is the cortical and subcortical pathways, damage to this area. With that being said, although our focus today is on cerebral palsy, if there's damage to any part of the brain in, say, an adult who's had a CVA or has an upper motor neuron syndrome or TBI, and it's to these areas of the brain, you can have very similar manifestations or signs as a result of the damage to that part of the brain. Okay. I want to differentiate between a sign and a symptom also as we talk, because I'm talking specifically about signs. A sign is any abnormality that's indicative of the disease that's discoverable on examination of the patient. So this is your clinical assessment of what you're seeing. And a symptom is the subjective indication of disease or a change in condition as perceived by the patient. So an example of a sign would be this area in a cortical or subcortical area might be spasticity or increased tone in, say, the lower extremities. The symptom might be a parent comes in and said, well, my daughter seems to be becoming more and more of a ballerina because she's more on her toes much higher than she was before. Okay, so that's a subjective observation. I'm not going to try to split hairs between a sign and symptom, but just so that you know there is a difference between those two. So now we're going to talk about cortical and subcortical pathways. And this is damage to any of the ascending and descending white fibers that go to and from the cortex. The 5 noteworthy signs of a hemispherical lesion. The child doesn't necessarily have to have all 5 signs, don't need to be present for diagnosing of the syndrome. The first is spasticity, or an increase in muscle tone. Diminished learned voluntary movement, so a child's inability to walk, maybe sitting up, maybe reaching and grasping. You have hyperreflexivity. You have, when you're testing for deep tendon reflexes, you're going to have an increase in the response. So when the doctor has you sit down and cross your legs and takes a little hammer and taps a tendon of the patella, and you have a knee-jerk reaction. Okay, with a hyperreflexivity, the reaction would be very, very quick. Pathological reflexes, such as a positive toe sign in a Babinski or a Chaddock response. And you could also the child could present with clonus. And clonus is a rapid firing of the muscles. Primarily, I would say it's seen maybe more in the lower extremities than the upper extremities, but it could be in both. Okay. And as I said, the child doesn't necessarily have to have all of these, but if you see this kind of signs in the child, you know that there has been cortical or subcortical pathway damage. Many times with cortical and subcortical pathway damage, you have these, in addition to the movement, you have these 3 signs that are frequently associated. And the first one is dysarthria, and this is where the individual have very slurred, slow speech. You have dysphagia, which is difficulty with swallowing, or hyperemotionalism. This may occur right hemisphere lesions alone, especially it's more associated with males than females. Okay, these are the structures that are part of the second center that we're going to talk about, and this is the kinetic, that make up the kinetic system. So this is a cross section of the forebrain at the mid-thalamus. It's the area known as the basal ganglia, or the extrapyramidal system, or the striatal system. It might be called those three different things. And so this includes the caudate nucleus and payman, the globus pallidus, the subthalamic nucleus, and the substantia nigra. When you have damage to this area of the brain, it results in a dyskinesis. Will show signs of involuntary purposeless movements. I think this is a result of changes in tone. So you have hypertonia and hypotonia, and that fluctuation causes this involuntary purposeless movement. You can also have varying degrees of rigidity. Probably not seen so much in athetosis as you can in some of the other dyskinetic syndromes. And I specifically highlighted athetosis because that's the primary diagnosis that you're going to see in children with cerebral palsy. The other ones are dyskinetic syndromes. I wanted you to know what they were. These are not conditions that you're going to see with children with CP. So the major signs for a child with athetosis is going to be the involuntary purposeless movements and hypertonia with movement. The synergic system, and this is comprised of the cerebellum and associated nuclei and pathways. This picture is of the lateral view of the cerebellum. Is associated with perinatal pathology with anoxic and ischemic syndromes. These three common lesions are rarely seen in isolation. They're usually found in conjunction with brainstem encephalopathies and or lesions of the basal ganglia, the white fiber tracts, and or cortical lesions, especially border zone necrosis. They can be caused by asphyxia, which is impairment or absent exchange of oxygen and carbon dioxide, anoxia, which is absent or almost complete absence of oxygen, or kernicterus, which is a severe form of jaundice, characterized clinically by episiotonis, high-pitched cry, abnormal absent moro, and abnormal eye movements. And we actually have a child that we're going to see at the ARC that has this kernicterus diagnosis. Looking at the large and small cell cortical necrosis, we're going to look at the granule cells are implicated. These are the reason I point this out, not that you have to know the names of the cells in the brain, but this area of the brain is very vulnerable up to 37 and 38 weeks gestation. And as they begin to mature, they become metabolically more active. One of the things that concerns me, we've actually gone to the point of 40 weeks is full term, but past a few years, definition of full term has gone to 38 to 40 weeks. And some babies may be a little earlier. To me, the infants need to stay in the incubator, if you will, the maternal incubator, as long as possible, because there's a lot of issues that can result. Postnatal anoxia or ischemia tends to damage the large and small cells. The Purkinje cell dendrites are directly contacted to the cerebellum, which integrates information from muscle proprioception. The second major input to the cerebellum arises from the variety of brain stem cell groups that relay information from the cerebral neocortex. And these inputs have multiple climbers with multiple contacts. And one motor learning theorist proposes that these climbing fibers inputs carries error signals that are indicating movement has failed to meet expectations, and corrections are needed to make those adjustments. Our children with incoordination problems, with hypotonia, developmental motor discoordination, problems with timing, irregularities of acceleration, deceleration of movements, or maybe a slight tremor, may be a result of slight damage to this area of the brain. The border zone results in neocerebellar syndrome. The signs are hypotonia, incoordination, delays in initiation of movement, irregularity of acceleration and deceleration of movements, intention tremors, nystagmus on lateral gaze, dysarthria, and autism are all as a result of damage to this area of the brain. Because this area, this neocerebellar area, matures slowly over years, the symptoms may not necessarily appear until later. So it might not be until the child's 4, 5, 6, 7 years of age to see the results of damage that maybe occurred in the first few weeks of life. Damage to the deep cerebellar area results in, the end result is that you're going to have ataxia, tremors, and equilibrium or balance problems. Okay, now we're going to take a look at the limbic system. Okay, so one important role of the medial temporal lobes is in declarative memory processing. This includes what we term our working memory, which refers to the retention of information needed to guide ongoing behaviors, if you will. These are the 6 characteristics that comprise declarative learning. The first is semantics, and semantics has to do with the meaning of words or language. Facts are statements about things that we know are true. Symbols are used to represent something else. It's a concept that stands for another idea. It may be a visual image, maybe a word or a sound or a gesture or an idea. Episodic is made up of loosely connected episodes or events. It's and something that's really meaningful. Probably all can remember what you were doing, that maybe the very simple things that you were doing the day of 9/11, because that was a very significant episode. And there'll be other things within your life that you could remember that way, that you can relate to, whereas another day in your life may not be nearly as memorable. Okay. Your inner diary is your thought processes or feelings about something that was occurring. Again, this is the limbic system, so it is going to be tied in with memories, and emotions are going to be very much tied into one another. Emotions and memory are tied in very closely to our survival system. Emotions of anger, fear, or even feelings of pleasure are certainly very much tied into our survival system in terms of eating and sex in order to reproduce. The final system that we're going to look at is the visual system. And many of the children who have cerebral palsy have problems with visual processing, because the area of the brain, the occipital lobe, has been damaged, and they have what's called cortical blindness or cortical visual impairment, I think is the term that's used now. They can see, the input can come in, and there's the optic nerve may be intact, and so it's not like a child who's blind, but it is the processing of the information. Sometimes there is damage to the ocular motor muscles around the eye, which can cause the eyes not to work together. You can have double vision. You have monocular vision, where just one eye is working. You have stereopsis, where you've got crossing in of the eye. And when the eyes aren't working together, they're not going to process the information as well. So there's many issues that can occur for these children who have visual system impairment. Each optic nerve is thought to bring in 1 million axons or fibers, take the information to the occipital nerve. It's thought that 70-80% of all sensory information comes in through the visual system. They have implications for long-term learning and memory. Okay, so that was the 5 areas, 5 centers, major centers of the brain. Okay, so now we're going to look at the severity but signs of the child that relate to nervous system pathology. Some of the signs might be very subtle, barely perceive that there is a problem, and some they progress from minimal to soft signs to really hard signs, that it's quite obvious that a child has spasticity, or that they have a visual impairment, or there's problems with cognition. They may be very severe or very mild. So I've had children come in that I've had the privilege of being able to look at their brain scans, and who are significantly impaired, and you look at their CT or MRI brain scans, and you can hardly detect that there's any damage at all. And I've had children who have been very minimally involved. I can remember one time seeing the scan of a child who was hemiplegic, but she was ambulatory. She was using her upper extremities to do two things together. Now, granted, her involved side certainly had coordination issues, but she could open and close her hand, reach and grasp. She could manipulate objects very well. But when you looked at her brain, it was like that side of the brain was pretty much missing. You can't always tell from scans, and they don't also always correlate with minimal signs or real maximum hard signs. The diagnostic procedures with the use of different kinds of dyes and the different types of scans are much more sophisticated than they used to be, and I think they can be used to help with the diagnosis. Okay, so now we're going to look at some of the common causes of CNS pathology. These four areas, would be probably a good idea to know some of the problems that are associated with each of these. Your fetal or the neonatal state, this is the period of time, this is the newborn period that relates to immediately succeeding the birth and continuing through the first 28 days. Problems that can occur during this period of time that can leads to CNS pathology are things like asphyxia, and asphyxia refers to the decreased exchange of oxygen and carbon monoxide. You could have hypoxia, which refers to the shortage of oxygen, or you could have ischemic syndromes, reduction of blood flow. B is a result of placenta insufficiency. There might be the umbilical cord may have wrapped around the child's neck and cause strangulation, which would cause a loss of oxygen. Be due to some sort of congenital malformation, might be a prolonged delivery, the baby got stuck in the birth canal, might be mechanical trauma, they were born and they were placed on mechanical ventilation, sometimes with multiple births. There might be one twin might steal from the other, don't get the nutrients or the oxygen supply that is necessary. Okay, so those are some examples of some different fetal or neonatal problems. Perinatal state, this occurs between 28 weeks gestation and through the first 7 days after delivery. Okay, so there's different degrees of prematurity, and they look at it by the size or the weight, how many grams that the child is. So problems that occur with prematurity include respiratory distress syndrome, bronchopulmonary dysplasia, cardiovascular disease, congenital heart problems, intrauterine growth retardation, might be small for gestational age, connectorus, this is the nuclear jaundice, or it could be post-mature delivery, a child who is born over 4,000 grams. They're very large. They may have maybe that there was meconium aspiration causing brain damage. Maternal factors, the number one, are going to be drugs and alcohol. Teenage pregnancy, lack of prenatal care, malnutrition of the mother, diabetes, environmental toxins, anesthesia that might be used during delivery, radiation exposure, smoking, accidents, suicide attempts, problems at the maternal factors that cause CNS pathology. And then there are certain diseases that can lead to brain damage, and these include genetic diseases, rubella, measles that occurs pregnancy, meningitis, encephalitis, where you get infections of the brain, viruses, rotaviruses, AIDS, bacteria, parasites, hypoglycemia, and then the Rh incompatibility would also be a disease factor. Know 2 or 3 of the different conditions that in each of the categories. The 3 most common factors which predispose an infant to CP or CNS pathology, other than drug and alcohol, because remember I said those were the number one, and are respiratory system immaturity, cardiovascular, and then connectorus. Respiratory problems can occur from resuscitation following prolonged apnea, and so the infant's gone for a period of time without oxygen, which is going to cause brain damage. A sudden infant death or trying to resuscitate after sudden infant death would be another example of a respiratory system immaturity. Cardiovascular system immaturity, hypertensive states. The cardiovascular system might have damage. Because of immaturity, you're going to have capillary bed of the germinal matrix zone surrounding the ventricular system that could result in damage. And then jaundice The liver has a bilirubin, and if the bilirubin count is too high, it can lead to severe problems. So our cavities that store cerebral spinal fluid. Then the cerebral spinal fluid nourishes the brain. So just be familiar, know that there are 4 ventricles where their general location is in relationship to the brain, because that's going to be implicated in terms of problems that occur from damage to this area. Okay, children who are born premature are going to have an immature brain, and one characteristic of the immature brain is that there is the weakness of the blood vessels. And when there has been weakness, damage occurs. This can lead to a bleed or a hemorrhage of the blood vessels. The lesions can be unilateral or bilateral. Unilateral just means one side. Bilateral is both. They can be microscopic in size or very extensive. It can cause hemiplegia, which is damage to one side of the body, or spastic diplegia, which is more involvement in the lower extremities, or cortical blindness. Depending on the extent of the hemorrhage, you have 4 grades of a bleed. This is identified through a CAT scan or an MRI to determine the degree of the bleed. The grades range from being minimally involved to significant. So a grade of 4 is going to be the most significant. If you have a grade of 3 or 4, the hemorrhage involves 50% of the ventricular that's present or greater. These are our kids who are going to manifest with cerebral palsy. You might have the other 2, they may go completely resolved, or you might have some minor problems. But the immature brain as a result of prematurity and the relationship, remember we talked about the germinal matrix zone being very vulnerable during the last 2 or 3 weeks, and then if you have a child who maybe was born really early, like 28, 30 weeks gestation, this area is going to be highly likely to cause problems. So if you have subintimal hemorrhages which bleed into adjacent white matter, it's going to destroy the fiber tracts in the area of the hemorrhage. Very common functional losses that occur as a result of damage to this area are cortical deafness, cortical visual impairment, and spastic diplegia. So you can imagine with deafness, the damage in this area is going to bleed into the temporal lobe. The visual impairment is going to go into the occipital lobe, and spastic diplegia, the motor cortex. Other kinds of problems in addition to auditory, visual, and motor, just to kind of give you some additional insight into the problems that can occur. In the anterior medial temporal lobe lesions, this can cause problems with deficits in declarative learning, just like we talked about earlier. So these kids are going to have difficulty with memory, and they have trouble retrieving information. They have problems with emotional tone, might have problems with visual object and facial recognition as a result of damage in this area. Post-temporal lobe lesions, the kids are going to have auditory perception problems. They may have receptive aphasia. More extensive lesions might result in different kinds of dyslexia as a result of damage in this area. Parietal lobe, you're going to have, remember, somatosensory deficits. Children may have visual neglect syndromes. They may have problems with visual spatial orientation, stereognosis, body schema, any kind of somatosensory such as tactile, vestibular. So I know we're talking about cerebral palsy, but if you have, I think there's also implications for children brain damage as a resulting in other kinds of sensory processing issues that we're going to talk about with kids throughout this whole semester. And then prefrontal lobe lesions, this is going to be individuals who have diminished capacity. This area may cause inability to learn from it, may have difficulty learning from experiences, especially in relationship to judgment, or they can't relate present emotions to previous events. A child may have an inability to have self-motivation. They may have a flat affect or unpredictable behaviors. Okay, so now what I want you to do is I want you to go watch this videotape. It's a nice comparison. It's just the first 3 months of life. It might go up to a year. There might be several of them, but at least look at the first maybe up to 6 months of age, because it takes you through the normal development and atypical development and does a comparison. And I think this will be real important for you in terms of honing in your observation skills. Okay, so that's it for this first section.